scan and looking at your tongue, it fits. The weird part is your right tongue is kind of going back, if that makes sense. When I look back in your throat...
It's on the left side. All the stuff's on the left side.
Right, everything's on the left. So what I'm seeing kind of a little asymmetry there, where the right side looks like it's kind of heaped up more. And that may just be because there's more scar contraction. You know, when they target the one, when you know where the tumor is, they target the radiation to, right there, like that one spot. They hit the spot where the tumor is, the center of the tumor, with the biggest dose of radiation, and then as you get further away from it, they give less radiation. So it may just be that's just some scar tissue.
My epiglottis is deep down. It could do the same thing.
Epiglottis looks okay. I mean, the part that looks a little irregular is in the base of the tongue. So I think, with that information, I would check you again like in 2 to 3 weeks.
I still have my tube. I can't swallow if I aspirating.
Yeah, you got to hold on to your tube for a while. Did they tell you how you done your swallow test? Did they have to cut it short?
I didn't do good.
Didn't do so hot.
Yeah, I still have something going down my...
Okay, in your windpipe.
Before I didn't know it. Now I know it. I'm coughing it back up.
Okay.
So it's been a lot better.
So what'll happen there is you'll have to work with a speech pathologist.
I already am.
Okay.
I have been for 2 months.
It should get better. It should continue to get better over time. A lot of patients with base of tongue cancer start off with the G-tube, and then, 4 or 5 months after they're done, or treatment, or, give or take, they get it out, and they're good, But your scans, your physical exam looks worse than your scan does, and it's usually the opposite. Usually the scans look worse.
Physical scan, is it what you just did?
Yeah. But I'm reassured because your tumor is on the left, and that's the part that looks smaller. The bigger part looks like it's on the right.
Okay.
That'll
stay like that, I guess, right?
Yeah, that's what I'm trying to figure out. Because you had him. Here's the thing: you had your PET scan. Your treatment ended in June, right?
Right.
You had your PET scan when 2 months after that, roughly.
Yeah, 11 weeks.
Yeah.
9 weeks.
And then your CT scan that you just had was after that, and things got better between those 2 scans. The tongue got smaller, not bigger.
Okay.
You know what I mean? So you put that in context. We'll probably get another PET CT scan, another couple...
Yeah, they've got me lined up for another 8 weeks out from whenever it was.
Yeah. So what I might like to do is maybe split the difference. Let me see you back in the office in 3 to 4 weeks. Let's repeat the endoscopy. Just make sure it's not changing, Okay. And if that follow-up PET CT scan is negative, then I'll be very reassured that you're fine. It's just the scar tissue and the swelling and just the way it looks back there. I think this is like only my second time seeing you after surgery.
Right, no, yeah, first time.
This is my first. Yeah, this is the first time after treatment.
Yeah, right.
So yeah, that's the thing. That's one of the tricky things about head and neck cancer. The endoscopy is always going to be abnormal, and so you want to see, is it changing or is it stabilizing?
Okay.
You know what I mean? So I'm very reassured by the PET scan being negative and the CT showing improvement in the appearance of the tongue between the two times. So I think what I'll do is see you back in like 3 to 4 weeks. Let's do a 3-week follow-up.
All right.
And then I'll scope you again, and then I'll get a second time point to how things are looking. And then if it looks the same, then we'll go to that PET CT down the road.
Did you video today?
I'm sorry?
Does it take pictures?
No pictures.
It's in your mind.
Yeah.
Okay.
I have a pretty good sense of when I see that's abnormal. It's like seeing a face.
You're
right. I mean, I have some patients where I have pictures of their surgery. I recognize the pictures of the surgery to the patient. Yeah. So you get used to it after, because you're going to get this a lot. You know what I mean? Mm-hmm. You're going to be getting scoped either by Dwelvin or myself, Dr. Simmons, every month for a year.
Really?
Mm-hmm.
Just to make sure.
Close follow-up. Yeah. Yes, sir. Yeah. I mean, the majority of treatment failures occur in the first 2 years after surgery. So the first 2 years is when we're the most vigilant. Because if you have a recurrence of the tumor, then you got to have surgery. You can't give more radiation.
You can't?
No.
Oh.
Hey, buddy, I'm sitting across from Mr. Hill right now. No, I can pull it up here and look at it. This is the CT, or this is the PET. Okay, so it looks better. Yeah, it does. It's like the posterior tongue on the right is kind of heaped up, and that's the opposite side of his tumor. So I'm wondering if he just has a lot of scar contracture on the left. I mean, I'm reassured that it wasn't metabolically active, and I'm reassured that the follow-up CT showed improvement in the size of that thing. So what I was going to do is just see him back like in a couple of weeks, maybe 2-3 weeks, repeat his endoscopy, and then I'll see that the next time point will be your next PET CT scan. Okay. Okay, I'll mention it to him. Right. Right. Yeah. Well, sometimes I think what happens too. I mean, maybe it's sitting there in the inbox too, like with this Athena Healthcare with the EMR thing. The faxes come through electronically, and sometimes I'll get like a batch of like 30 faxes. Boom! I'll dump into my inbox all at once. And so I'm not sure how that works. But the other option is just give the patient the disc, put it on put on a disc and give it to the patient too. That'll work as well. Excuse me one second. Different patient. Yeah.